Dr. Kumar will talk about externalization, stenting, and completion.
Respected Chairperson, actually some of the slides will be mixing up. The externalization of wire, retrograde wire across the CTO, wire is in the proximal true lumen, corsair or the microcatheter pushed to the antegrade catheter, guide wire should be long enough to take into the externalization. You can exchange the short guide wire for the long wire, or you can snare the long wire, or antegrade wire pass through the CTO segment and then do the intervention through that. Externalization of the wire brings tensions in the coronary artery, so extreme care should be taken. You should avoid a deep seating of the retrograde catheter, avoid unintentional advancement of the retrograde catheter, avoid donor vessel dissection. The externalization can just be with a wire or with a microcatheter. You can use a stent, you can use a guide liner, you have an endeavor technique and snaring. The first case, this is a typical retrograde wire crossing. You have a wire coming inside, CTO segment crossed, your wire is taken into the guideline, into the main lumen. This is actually the wire crossed. When the wire is crossed into the antegrade catheter, you have to push. Next is actually the antegrade. When you wanted to push the wire, what you can do is actually, you just do a balloon inflation there. You can see the next slide, the second slide down. You just with the balloon, with the help of the balloon trapped in the antegrade catheter, you can push the guide liner down or push the corsair into the antegrade catheter, then that externalization is finished. So after that, externalization. But there are some situations only wire cannot go. This is actually a wire crossing. When the wire is actually, we try to push the wire into the antegrade catheter, wire is not going up. When the wire is not going up, probably there is a small CTO segment in the antegrade place. So in that situation, you can do a reverse cut and then wire can be pushed in. Now the wire is easily can be pushed through the subintimal tract or something. This is actually the second situation where a balloon can help, the wire can be taken into the antegrade catheter. So the wire is actually taken down, finished. This is a third situation where you have a antegrade CTO. You can see the CTO segment in the mid RC, mid LAD already stented. You can see a mid LAD occluded, branch at the site of occlusion. Vessel has an angulatory entry, no calcium seen. So the wire is actually entered. We can see the wire entered into the diagonal. But you can see there is a distal lumen. Wire is in the lumen, but junction with the LAD, we have a dissection segment there. Once you have a dissection, we decided not to stent it. We decided to go retrograde because of the excellent collateral seen. But the collateral wire, we taken with the cyan black. The cyan black is not going. We have taken both in the subintimal. Two wires, Gaia second tried, Philrex tried, but the both wires are in the different planes. It can be in subintima or one in subintima and other one can be in intima. We took a Gaia third wire, not crossed. So when the Gaia third was not crossed, we took a guide liner there. With the help of a guide liner, we have taken guide liner is taken, this wire is not crossing, with the guide liner push into the normal lumen in the antegrade vessel. Then we have taken a Miracle 6 wire, the second frame, the Miracle 6 actually crossing into the guide liner. Once the wire is going into the guide liner, then you have to take the corsair up. So the guide liner is crossed. Once the guide liner is crossed, then you have to take the corsair up. For taking the corsair up, you integrate wire, you can take a balloon and balloon trap, and after trapping the balloon, you can take the corsair up. So the corsair is now crossed, is pushed into the guide liner. Once the corsair is pushed into the guide liner, you can remove the antegrade wire and finish the guide liner is removed, corsair in the antegrade catheter, Miracle wire is exchanged to RG3, corsair taken back into the septal artery, then finish the procedure. This is what, now this is the procedure like this, and removal of the wire with the corsair. You should avoid the deep seating of the both antegrade and retrograde catheter. You should be very careful about these things. That is the final result. So the guideline assisted capture technique is like this. Your antegrade wire and retrograde wire. You have the guide liner coming down. taken the guide liner, the retrograde wire is withdrawn back, taken inside, finally pushed inside, and that is externalization. It's called capture technique. See, another way is actually Gayatri wire, retrograde catheter, filled FC, and antegrade catheter. We push the wire down. Once the wire is going down, we decided to take a corsair because nothing is happening. So we have taken a guide liner there, guide liner in the antegrade catheter. The wire is, we pushed, wire is not going. The Gaia third in the retrograde wire, guide liner in the antegrade wire, pushed the guide liner much more down. Change the wire is not taken inside. So now the wire is pushed inside into the guide liner. The balloon removed from the antegrade catheter, shifted antegrade wire, guide liner distally, Gaia third wire moved into the antegrade catheter, then corsair moved into the antegrade catheter, and this is the final externalization. This is actually the final result. We get a very good result. The actually Rendo's techniques actually another way. This is actually a stented LED stented vessel, RCA CTO. We are going with the corsair. This is actually the wire shifted. The first wire did not take the capture. This wire has taken the septal branch. After the septal branch, we could take the wire through the septal branch down because the antegrade wire has already created the dissection. This is actually caravel with the wire is not going down. The wire is gone, the Gaia second wire. The wire is actually taken, only wire. No, the microcatheter is down, actually the caravel is sitting down. We have taken the wire, angulated the catheter. Once the angulator, you can see the wire is pushing. We are just trying, putting the guide liner, actually putting the guide catheter just tilting up, taken. It is again going down. It is not in the right position. So we push the wire catheter up, changing the position of the guide catheter. Just push, change the wire. Okay, now the wire enters. Once the wire enters, we thought we don't require all the time guideline RG3 wire. Just the wire is actually in the antegrade catheter. You have a microcatheter coming from the antegrade catheter. Your retrograde catheter wire is already in the catheter. We decided to do a rendezvous inside the catheter. So what we did is actually, you can see, the wire is pushed back. I am trying to take the wire into the microcatheter inside. Wire is outside. How I identified? Because the wire is not touching the other wire. I taken the wire easily, so I decided it is not the right one. Sorry, can I go back? Can I go back the slide? 2 slides. One more slide back. Back. Okay, just run. Yes. 3 minutes are there, sufficient time. You can see the wire is not going inside, so I decided to keep the wire. The antegrade wire is in the microcatheter, the retrograde wire, oh my God. How can you go back? Automatically going. Can you go back? Go back. Go back. Okay. Just keep it. You can see the wire I am pushing, but it is not in the right track. I understood that because this wire, the antegrade wire, is easily cross the microcatheter, but retrograde wire is in the different plane. Once it is in the different plane, what I decided actually, I kept the wire in the antegrade wire and removed the retrograde wire again. I decided in the same angle like this, I pushed the wire making a curve there. I just went inside, touching the antigrade wire in the microcatheter. Once I touched, it enters. Now it enters inside. Once it enters, and threading down, once I thread, I understood the wire is not going, then I removed the antigrade wire. I pushed the wire down. When I pushed the wire down, I pushed the antigrade catheter down as distal as possible. Then I pushed the antigrade microcatheter as distal as possible. Then I removed the caravel down. Once I removed the caravel down, you can avoid a RG3 here. You can just remove this, push the microcatheter down. I'm just pushing the microcatheter down. When I push the caravel down, I'm pushing the microcatheter also down. I push totally down. After pushing it down, I cross the CTO segment. The microcatheter pushed the CTO segment down because there is a wire inside. So I push the microcatheter down. Once I pushed it, then it is very simple. Taking the antigrade wire as fast as possible, finish the procedure. Now I'm taking the antigrade wire through the same microcatheter because I am in the vessel is there. Then the wire is coming down. Here the wire. You can see the antigrade wire coming down through this one. I put an antigrade wire. Antigrade wire coming down through the microcatheter down, and then no problem, finish the procedure, and you can avoid a retrograde RG3 wire also in this case. So you can use a snaring technique, which I don't do usually, but there are a lot of people do the snaring of the retrograde wire and finish the procedure. Thank you. The next ijcto will be on Delhi, 5-6-7 June 2020. Thank you.
Thank you very much. We don't have enough time to discuss, so we'd like to close this session. I hope this session will be helpful in your daily practice from now on. Thank you.
Thank you very much, Chairpersons. Ladies and gentlemen, that